Good evening, one and all, respected members of the faculty, panelists, experts, and all the attendees. I, Dr. Yashika, welcome all of you to this CME on Induction of Labor Optimizing Outcomes, organized by the Safe Motherhood Committee of AOGD under the aegis of NARCHI. So, every birth is a natural birth. Each of us is a part of nature, and nature is always stunning in its variety. With above said, we also know that labor induction is a thing we as obstetricians are well aware of in order to facilitate the birth of a healthy baby and to ensure a healthy and safe mother. So without much ado, let's start our CME today. I would like to start by inviting Dr. Manjupuri ma'am. I would like to start by inviting Dr. Manjupuri ma'am for the welcome address and introduction.
So very good evening to all, and it is indeed my pleasure and privilege to welcome all the guest faculty, Dr. Asmita, who is the president of AOGD, the experts and the faculty and the delegates for this very important webinar on induction of labor, optimizing outcomes. In a series of webinars which have been organized by Safe Motherhood Committee, we have had some very focused webinars based on what we feel needs to be kind of discussed and addressed. And it is about the subjects which have got a lot of gray areas. So now induction of labor is something which is very commonly done. And we have seen that the rates of induction of labor have been gradually and slowly rising because everyone has started thinking that this is a convenient way of getting babies out at the right and convenient time. So as the indications of induction of labor are expanding, so is the new evidence which is emerging, which is actually focusing on the time which is spent by the newborn in the womb and its importance. So everyone is now emphasizing that the baby should be able to spend maximum time in the womb to attain optimum maturity. Otherwise, it gives rise to a whole lot of problems like lower IQs, autism, a lot of diseases later in the life like hypertension, diabetes, obesity in the newborn babies. So that is why it is important that we do not venture upon or resort to induction of labor just because we are scared of monitoring the pregnancy further, so that something might go wrong with the baby, then how would we explain? So it is much better to induce labor and say at least we are doing something, because it is actually a stepping stone onto the which is contributing heavily to the rising cesarean section rates. So these two things are very closely linked, and that is why like Yashika said, natural is always the best. So whatever pains the patient feels in natural physiological labor, they are much lesser vis-a-vis what she actually gets to feel when the labor is being induced. So every labor should be decided with a whole lot of responsibility. And we also need to decide on the, in addition to the right time, also to decide on the right method. And we need to take proper care during the process of induction, so that no harm is done to the baby or the mother. So with these words, I would lay this topic open for discussion. And before that, I would like to invite Dr. Asmita to say a few words. Over to you, Dr. Asmita.
Yeah, thank you, Dr. Manju, and good afternoon, everyone. At the outset, I must congratulate Dr. Manju for choosing this very important topic for today's e-webinar. with its associated medical risk, more discomfort to the woman, and a strain on the healthcare resources. Induction on labor is an intervention which should be really used very judiciously. And as Dr. Manju rightly pointed out, with expanding incidence and indications, some of them clearly beneficial to both mother and baby, and some probably needing little more scrutiny. The scientific program is really very thoughtfully designed today, which will cover the difficult as well as gray areas in induction of labor, and look forward to a great learning. Thank you so much.
Thank you, Dr. Manju ma'am and Dr. Asmita ma'am, for the encouraging words. So with these, we will start with the debate of the first session today. And for the debate, we would like to invite our experts for the session. Dr. Reva Tripathi ma'am. Ma'am is Senior Consultant and HOD, Obs and Gynae at Sitaram Bharatiya Institute of Science and Research. And she was former professor and head Department of Obs and Gynae at Hamdard Institute of Medical Sciences. Ma'am has more than 65 papers in international and national journals and has contributed to chapters in more than 40 books. Ma'am has also led various research projects and has been a member of various expert committees. So we would like to welcome ma'am as an expert in this session. We would also like to invite Dr. Manju Khemani ma'am. She is Director, Department of Obs and Gynae at Max Super Specialty Hospital. Ma'am was also the past chairperson of Endometriosis Committee of AOGD and of the Safe Motherhood Committee of AOGD. Ma'am, we would welcome you. So speaking for the motion, we have Dr. Sakshi Nair. Ma'am is a young and energetic consultant in the Institute of Obstetrics and Gynecology at Sir Gangaram Hospital, New Delhi. She's also a member of the AOGD Endoscopy Committee 2021 to 23. Speaking against the motion, we have Dr. Jyoti Bhaskar. Ma'am is an excellent orator, and she is currently working as a clinical director at the Apollo Cradle Hospital at Indirapuram, Delhi. So we will begin our debate. The topic for the debate is routine induction at 39 weeks in a low risk nullipara.
So good evening, everyone. Yashika, can you please stop sharing your screen so that I can share my screen?
Yes, ma'am.
Yeah, thank you. So before, just a minute. Let me just. So before I actually start, I would like to confess that as a postgraduate from GTB Hospital, then as a senior resident in Lady Harding Hospital, and now being a consultant in a private hospital, Sir Gangaram Hospital, till date. Just let me start my slide sharing before I start. I'm having a little problem, I'm sorry. Just a minute. Yes, can you all see my slide, please?
Yes.
Yeah, thanks a lot, ma'am. So now being a consultant in Gangaram Hospital, till date, we have been practicing induction of labor beyond 40 weeks in a low risk nulli gravida. So when I was called to speak upon this topic, I actually went through the literature in the last couple of weeks and then actually opened my eyes to a new possibility, which I wasn't even aware. And now let's start. Why is there a rationale for induction at 39 weeks of gestation? Because it has been recently been seen that there's an increased rate of perinatal and maternal complications beyond 39 weeks. And there are a lot of ethnic differences resulting in the earlier maturation of an Asian fetuses. And why? What is the basic reservation at 39 weeks? As ma'am said very nicely, we see when we induce electively, there have been an increased rate of cesarean deliveries, and there have been an increased rate of adverse maternal and perinatal outcomes, which have been according to the pre-existing studies. But the pre-existing studies have compared the induction of labor with spontaneous labor. They have not compared induction of labor with expectant management. Expectant management can actually land up either in induction of labor or can land up in a spontaneous onset of labor, which we don't know. So biggest challenging evidence came in 2018 by Grobman et al. In ARRIVE trial, which was basically a randomized trial for induction versus expectant management in nulli gravida patients. Amongst 41 geographically dispersed centers in US, 6,100 patients were selected, which were equally randomized into induction and expectant management group. And their primary outcome was the perinatal death or the severe neonatal complications, which include multiple things like admission in the nursery, HIE, infections, etc. Secondary outcomes were cesarean deliveries, hypertensive disorders of pregnancy, numbers of hours in labor and delivery, stay in the hospital, and the patient satisfaction. Now let's see the outcomes. There was no difference in the primary outcome between the induction group and the expectant management group. But surprisingly, there was a decrease in the cesarean delivery rates in the induction group, significant decrease in the hypertensive disorders of pregnancy, and decrease in the neonatal respiratory support as well. These all were significant. The length of the stay before the delivery was longer in the induction group, as rightly because the patients were induced, and shorter in the expectant, but postpartum stay was seen longer in the expectant group because they either had to wait for the baby to come or they had a cesarean section, that is why. But patient satisfaction was found to be more in the induction group because they were better in control of the situation. So after this ARRIVE trial, a meta-analysis was conducted by Alexandros Solitaris, who studied 5 studies from 1975 to 2018. This is an accepted article. It has still not been published. He studied the primary outcomes being cesarean section, maternal death, and nursery admissions. And secondary outcomes were operative vaginal deliveries and grade 3-4 perineal lacerations, PPH, hypertension in the maternal disorders, and maternal infections, thrombotic events, length of hospital stay, need for nursery support, and cerebral palsy, etc. The outcomes. Again, he calculated the evidence also and the numbers needed to deliver in case of when the evidence was moderate. The number of cesarean deliveries were significantly less in the induction group, and with a moderate level of evidence, the numbers needed to deliver were 32 for preventing 1 cesarean section. The hypertensive disorders were also less with moderate evidence, and the numbers needed to deliver were 21. And neonatal respiratory support was also less with a moderate level of evidence, and the numbers needed to deliver were 83 to prevent 1 nursery respiratory support. So the inference was that there was a decrease in the cesarean rates in the induction group without an increase in the instrumental deliveries. Women who continued the pregnancy beyond 39 weeks are generally seen less likely to respond to the induction as the pregnancy progresses. There are increased chances of having a big baby, macrosomic babies, and high chances of cephalopelvic disproportion. There are high chances of fetal distress because when the babies become big, the placental reserve to supply to the baby also becomes less, leading to fetal distress. Induction at 39 weeks prevents any hypertensive complication because, as we all know, as the pregnancy we wait, the hypertension can develop later. There is a reduced need for respiratory support. Maybe the author said it might be related to the reduced meconium exposure because, as we all know in our practice also, beyond 39 weeks, we do see an increase in the meconium till the time we wait till the delivery. And one of the studies did quote that meconium does increase the respiratory distress by 3.3%. So, and stillbirth rate, as we see, beyond 32 weeks of gestation, the risk of stillbirth increases gradually, maximum being at term. Like we can see in this red graph, that the risk of stillbirth gradually increases from 37 to 42 weeks. So the term stillbirth can still be avoided by judicious labor induction. But if I say, let's induce at 37 weeks to avoid a stillbirth. But if you see the blue graph, the infant death is highest at 37 weeks because the chances of SIDS, and as ma'am said, the mental maturity is also very less at 37 weeks. So we need a balance between the risk of stillbirth and the infant mortality rate. So if we see the blue graph, the infant mortality rate is the least at 39 weeks. The stillbirth chances, though, little higher than 37 weeks, but it strikes a good balance between the stillbirth rate and the infant mortality rate. So in one of those articles, Scott W. White has quoted, if it is true, a fetus cannot be a stillborn at 40 weeks if it was electively delivered at 37 weeks. I don't say deliver at 37 weeks, but we should have a balance between when to deliver so that we have the least infant mortality and the least chances of stillbirth also, because stillbirth does give nightmare to anyone. So the Negley's rule, why are we following 280 days of pregnancy? Because a German obstetrician in 78 in his book mentioned 280 days of confinement of pregnancy. But does one size fit all? Gerald Whitman Lawson recently in 2021 in ANZOG, he actually studied the Negley's rule with effect from ethnicity, maternal height, maternal age, maternal weight. And he actually said that all play a very important role in determining the length of pregnancy. And he concluded that Negley's rule should be considered as a guideline, but not a definitive date. Okay, when should we deliver? So as I studied the literature, a lot of ethnic differences does exist in the length of the pregnancy. A study in 2004 was conducted by Roshni R. Patel in 122,000 pregnancies with spontaneous labor and concluded that the median gestational age in Africans and Asians was 39 weeks and 40 weeks as compared to the European women, which was done in spontaneous labor. Then we have another one in 2013. She claimed that with increasing gestational age beyond 39 weeks, the perinatal mortality rate increases most strongly among the South Asian, African, and the Mediterranean women as compared to the European white women. Also in 2014, Rosentin et al. Said the mortality risk of expectant management exceeds the risk of delivery at 39 weeks in all the racial and ethnic groups. So I would like to conclude with all of this data that Caesarean rates, hypertensive disorders, and definitely neonatal respiratory support definitely decreases if we induce the patients at 39 weeks and do not go beyond 39 weeks, specifically if I see the ethnic differences. But do we say that 39 weeks is the new 40? I really don't know, but we do need an Indian arrived trial, as the French arrived trial has begun from 2021 and it's going to end in 2023. We need to update ourselves and need to do an Indian arrive on our ethnicity, on our population. Thank you, ma'am.
Thank you, Sakshi ma'am, for your words for the motion. Now I would like to invite our next speaker, Dr. Jyoti ma'am, to speak against the motion.
Thank you so much for having me here in a debate. It's been ages since I've done a debate, but I have been fortunate. But 8 months ago, that was the NACHI conference, and Dr. Asmita is here. We had debated the same thing. Low-risk pregnancy. Should we go beyond EDD? And I had stood there. And I had stood at the same podium and spoken very vociferously and tried to convince all my fellow obstetricians, yes, we should go beyond the EDD. But it's sad that 8 months later, again, I have to stand here to again convince my obstetricians, do not be brutal. I need to really denounce the brutality that instead of 40 weeks, we are further terminating 1 week of the beautiful relationship that the mother and the fetus enjoy and deliver them electively at 39 weeks. I would say let nature take its course. We all have a very short memory. I'm sure each one of us has forgotten the flash floods that took place in Dharamshala. We have forgotten the slides that took place in the hills of Shimla, the tsunami, the fire which rages down in the various forests. When we play with nature, the nature plays back with us. And when nature plays back with us, the game actually becomes extremely serious. So I would say this is not just a debate. It is a time to take a call. We are here to take a decision, and once and for all. And we're going to decide in favor of our women. As rightly said, in low-risk pregnancies, as well in all pregnancies, what is full term? It starts from 39 weeks and ends at 40 weeks, 5 days. And this definition has been given by ACOG and SFM in 2013. Then why are we obstetricians wanting to finish this journey the very first day that they enter into the full-term pregnancy, that's at 39 weeks? Why are we so scared to reach the edge of the cliff? That's the AGD. What are our fears? Which shots are we really scared of? Let's address them today. The shots. As Dr. Sakshi also said, the potential complication of continuation of pregnancy, the high blood pressure, the large date babies, I would say, would a week make a difference? As Dr. Sakshi said, that for the Asian population, it's 40 weeks, the mean gestational age. So we're just talking from 39 to 40 weeks. Would that really make a difference? Or is it the inconvenience to the mother and obstetricians of continuation of pregnancy, which Dr. Manju did address and is a major issue nowadays, that we want to induce them at 39 weeks? Or is it the biggest fear, the increased risk of stillbirth? I was hoping Dr. Sakshi would show this particular graph, because the moment you have a look at this graph, you say 39 weeks, it's increasing. The stillbirth rate is really high and we all get scared. Let's deliver them all at 39 weeks. Let us make it more simple for each one of you. If I do not deliver my woman at 39 weeks, in the next 1 week, the chance of stillbirth is 4 per 110,000. If she doesn't deliver at 14, we take her to 41, the chance of stillbirth is 7 per 10,000. Now look at this graph. These are 10,000 squares. And just, can you find those little blue spots? Just 4 out of 10,000. In absolute, it seems high, but when you see it visually, it's not so much. Putting it into a real life situation. If I do not deliver my lady at 39 weeks, then 4 will have stillbirth out of 10,000, which means that 9,996 will not have a stillbirth. Fact that I will have to introduce 2,499 pregnant women at 39 weeks just to prevent 1 stillbirth. Isn't this a huge price to pay for our fears, especially in a country like India? Have you ever considered the huge cost, the strain on resources, the infrastructure, the staff, and the mammoth logistics? And what about the mother? Have we ever even taken into consideration the wishes of the mother? None of the research evidences have looked at the preferences of the woman. These are non-medical factors, but they play an important role in the individual's decision. If you actually counsel her and tell her that if you go in for an elective induction for no medical reasons, you have a chance of cesarean section, of uterine tachysystole, of having epidural anesthesia lying down because of continuous fetal monitoring. And if you tell her what are the benefits of expectant management, the cognitive benefits for the baby as you continue the pregnancy, the fact that the baby will have a decreased need for special education if we continue the pregnancy, you would see that 73% would refuse medical indication. And this is from a RIFE trial. They had recruited 22,000 women and only 6,000 agreed to go in for a medical indication. So if you really look at the woman's choice, hardly anyone would like to go in for a medical education. And as Dr. Sakshi has really talked about, why is this bus deliver at 39, deliver at 39? It's only because of this trial, the ARRIVE trial, 2019, an open article which has been released by NEGM. But question that I would like to ask all the audience who's here, how many of you have actually read the original article? What is the source of information of yours for the article? Initially, like me, many of you must have seen it only on news, the NDTV blaring around, the NBC saying, it's safe, let's introduce at 39. But very few of us have actually read the article. Did you know that it was only carried out in USA, as Dr. Sakshi said? Not a single Asian or an Indian hospital was included. It only caters to the population of US. The expectant group is a very mixed bag. Spontaneous, the ones who are medically for reasons induced or who reach 42.5 weeks and have been induced. And the most important factor, there has been no cost-effective analysis which has been done in this particular study. So the conclusions, rightly as Dr. Sakshi said, but it's always 2 ways to look at the same conclusion. Inducing labor at 39 weeks did not, I would like to report, did not improve the primary outcome of serious complications to the baby. Did it look at that delivering at 39 weeks would reduce the stillbirths? No, it did not, because the size is so small, it's just about 6,000. And we are talking of 10,000s which can cause a difference. So neither did it look at stillbirths, whether it was being reduced, neither did it find that there was any benefit to the baby if we tend to deliver them at 39 weeks. Yes, the secondary outcome, there was a lower cesarean rate section, there was a lower risk of developing high blood pressure, but it's too true. It's too good to be believed. I would say it's too true to be believed. If you really take a handlens and look at this particular and read in between lines, you would find that the participants had an unusually high rate of developing blood pressure after 38 weeks of pregnancy. And maybe that is the reason that in the expectant group, they landed up with higher cesarean section. And the authors suggest that you should use the same induction protocol that they have used, which cannot be globally practiced. Thus, we really do hope that researchers will publish yet another secondary analysis that will give us a better understanding that why did they have such a less rate at 39 weeks because of the induction. 4 years have passed since this trial came. Has it been included in any guideline? WHO, RCOG, ACOG, SOGC, FOGSI? The answer is no, not as yet. ACOG did all was to release a particular statement. It's reasonable to offer elective induction to the first-time mothers at 39 weeks who are low risk, but they urge the providers, please take into consideration the values and preferences of pregnant women, the staffing and the facility status of your hospital, and the protocol for failed induction. And as always, the strong midwives of the Western, they were the one who actually stood up, and they said they would continue to promote normal, healthy physiological birth and a woman's right to make the decisions during pregnancy. They would not go by the ARRIVE trial. And they also proposed that all the money that you're going to spend on doing the induction, use that money to provide continuous labor support from the whole, and probably you will reduce your cesarean rates far more than inducing them at 39 weeks. Thus, coming to the end, I would just say that pregnancies which continue to be low risk at 39 weeks, counsel them with evidence, but first overcome your fears. Make your protocols which are suitable for your woman, your country, your economy. Monitor each and every pregnancy which goes beyond 39 weeks and let the nature take its course. But if medically needed, please do intervene and not just leave it to the nature. And I would just request everyone once again, and I hope this is the last debate we're going to have on this particular topic, let the saplings emerge on its own, respect the nature and be natural. As Dr. Manju started with it, I thought she was in favor of me at the very start, that let's be natural. Do not take a blanket induction at 39 weeks. Thank you so much.
A heartfelt thank you to Dr. Jyoti and Dr. Sakshi. Very nicely spoken, both of you. And I think that the real controversy or the real debate is between 41 weeks and 39 weeks plus, rather than 39 and 40 weeks, because a lot of us are inducing at 40 weeks, and we want to know whether that is justified too in low risk nullims. So let us hear our experts, Dr. Manju ma'am and Dr. Reva. Dr. Manju, ma'am, please start, and then we'll go on to Dr. Reva. I think Dr. Reva is a big proponent of 41 weeks, if I'm not mistaken. So, ma'am, you start, and then Dr. Reva can take over.
I must congratulate both the speakers. Sakshi, when I heard you, I said, wow, brilliant. And when I heard Jyoti, I said, okay, I must go with the Jyoti. Now, this is my interpretation of this ARRIVE study. So I feel it's a flawed study. Right. So what they have compared in the study, they have induced patient at 39 weeks, and other group they have carried till 42 weeks plus 2 days. And these patients who were waiting till 40 weeks plus 2 days, they have started monitoring only after 41 weeks plus 5 days. Isn't that a big flaw? Who does like that? And in this whole study, they have done all the parameters, but they did not tell us how many patients went into spontaneous labor and at what gestation. These two important things have been missed out from the study. Another thing, so an induction group did not have any prior losses. So they also concluded that 1,675 inductions have to be done to prevent one stillbirth, right? And that's not a small price. Stay in labor room is absolutely very high. We all know that, right? I was really wondering, why did they say that, patient had less pain? I mean, they did not elaborate, what method of induction or what method of pain relief was used. Even in their supplementary, I went to their supplementary. So what, they should have compared, induce at 39 weeks and compare it with, spontaneous labor. Then they could have told us, the difference in the stillbirth, the parental mortality and all those things. Because why will there be a difference, in parental mortality from 39 to 40 weeks or 40 weeks plus 5 days? And yes, I do agree about the Asian population, right? And if you see the NICE guidelines are as recent as 2021. They have not included, as Jyoti rightly said, and they say when you're inducing, you have to tell the patient that she will require more PV examination. There'll be need for ventouse and forceps. There's a risk of hyperstimulation. It's more painful. All these things have not been mentioned in the ARRIVE trial, and they've all said, good, everything good at 39 weeks, right? And induction may not be successful. And that's last point. We all know that, at 39 weeks, there are some risks if you continue pregnancy beyond 41 weeks plus 0 days, right? They induce patient at 39 weeks. So if you read the, how many patient will deliver at 39 weeks, 50% patient will go in labor at 39 weeks. If they had waited till 40 weeks, 80% would have delivered without any need for hospitalization, induction, close monitoring, so much of stress to the patient and our relatives. Not only that, beyond 41 plus 0, there's an increased risk of, cesarean section and increased risk of baby going to the NICU and stillbirth. And so why induce at 39 weeks? Why not wait till due date? So I do not agree with this at all. If you see all the meta-analysis which have been done before this study, they all said that induction is fraught with danger. After this particular study in 2018 by government, everybody just, gulped it, without analyzing what are its flaws. That's all.
Thank you, ma'am. Thank you. Dr. Reva, ma'am. Ma'am, I think you're muted, ma'am.
Yeah, I've unmuted myself. So this is a big debate. Of course, I would congratulate you all for having taken it up. So there are pros and cons to both. And as you rightly said, Rinku, I've always been a proponent of natural labor and going on till late. But when I read this study, I was kind of taken up by it, that how come, their figures speak what they speak. And I was very skeptical. I still am, I must say. But I actually started a PG thesis on this topic, which has the limitations of a PG thesis, because obviously the numbers are less. And I can't claim to say that we are actually mirroring the trial. But I would also like to say, on the other hand, that we are not seeing too much of a problem. So that goes as much as there. The points I think that we need to take into account is our situation, our scenario, our induction protocols, and keep in mind things like when they're talking about induction, they're talking about use of, very specifically titrated oxytocin and one-to-one nursing and continuous monitoring and all that. Now, as Jyoti rightly said, can we extrapolate all of that to our settings for all and sundry? In some specific niche hospitals, maybe, yes. But overall, for the country as a nation, can we do it? I think that the numbers are too small, and this is a very gray area. I would put it as a gray area, though the study doesn't say so. But, they haven't also talked so much, as Manju also said, about their induction protocols in great detail. And more than that, the biggest issue is, what do you do when a low-risk primary does not go into labor? Are you going to offer a section just because her induction has failed. Otherwise, she's at low risk priming. So it's a problem of the treatment that has been given. So are we going to subject her to a cesarean for that? This detail is not there about how many cesareans have been done for failed inductions. And failed induction has always been a problem to kind of delineate that when exactly are you going to call it a failed induction? Are you going to go whole hog, first put prostaglandins, then give a break, then give oxytocin, then do an ARM, then wait? Now, what we've seen in the, as I told you, the small study, many patients tend to kind of give up in between because they're really fagged out by the whole process, which is obviously not there when a patient goes into spontaneous labor. So I think that a major problem with this is that we are not talking about how we are counseling our patients. Are we counseling them that going into spontaneous labor is a better bet for you? Or are we counseling them that this is the best thing, you opt for it? But people do have their reservations about going against nature. And I think that you need more stats than what has actually been presented by this one trial. And the very fact, as Jyoti rightly said, that it has not been endorsed by other technical bodies, doesn't say too much for the trial. I know that there are problems. I remember when I was very, very junior, I think must have been early 90s, I actually had a good opportunity to meet Professor Chamberlain myself. And I asked him, what do you do for post-date? He said, what do I do? Just monitor the patient. I said, well, how many weeks? 40, 41, 42? He said, you keep monitoring. You have got all NSTs and ultrasounds and everything. Why you want to induce? This is the modern zamana. Why inductions? So, these pendulums, I think, also swing from one end to the other. And what we're talking today need not necessarily be something that will be applicable 10 years down the line. And I do also agree that with a country that has got vast differences in healthcare facilities and healthcare infrastructure, to kind of make it a standard protocol to just induce everybody at 39 weeks may not be the most practical of suggestions. Yes, it is very difficult to go against a particular study which is published in such a prestigious journal, NEJM. So you can't really write it off. I mean, at least I wouldn't make so bold as to do that. But I do think that we should take it with a little bit of a pinch of salt and see how things are. And, I'm myself still very skeptical about the whole issue, despite the study and despite the fact that the small amount of patients that have been done at Hamdard, which I've just recently left, are saying that it's not such a bad idea. But I think our patient inclusion has some suboptimal points, which we may not really quite disclose at the end of the trial, but I think within our hearts, we do really know that that is there. So now, kind of, I know people are going to say, well, you're neither here nor there. But I think at this moment, the time is to take a middle path, not to write. I would not, as also Manju said, that both the speakers did present their views very clearly and very well. And so you feel like aligning yourself with either one or the other. But I do think that treading the middle path for the moment may be the call that you wish to take. And what has not been spoken of at all is that a planned labor suits obstetricians. That is something, and we tend to, how comfortable it is if you don't have to do a 24/7 obstetric service. So that I think it's unwritten. It's not talked about in the article at all, but I would not go away from that point. And I do think that we need to, extrapolate these findings to our own settings, our own situations. And with due apologies to that New Zealand study or the Australian study, which was quoted about ethnic differences, from the time I'm a postgraduate, I'm hearing about this story about the Asian babies maturing quicker. But I think this is something more that has been a word of mouth thing rather than any great scientific evidence to it. We have all seen when we are not talking, we're talking in this era of using uniform charts for size. I think there's a greater difference in that rather than in talking about the length of gestation. So we do need to customize things to our own situation. And I think we need to take the study with a pinch of salt, some more detailed studies, taking into account our own situations before we can really opt for one or the other. Thank you.
Thank you so much.
I just want to add one more thing.
Sure. Sure.
So, Dr. Reva, it is not hearsay that, stillbirth rate is much higher in Asians. If you go beyond, it is what, they have given us the figure in NICE guideline because they have their own health data and where they have all kind of populations. So that's for true. They say that, in Asian population, not Indian, Asian population, the stillbirth rate is higher if you go, and especially a patient who has been deprived, before when she was born, during early childhood, One thing, secondly, why, in this particular trial, the cesarean rate is less? Because they stuck to the time that even when the complete right cervix is there, they gave the patient 12 hours if she did not go in labor. And plus, when they started syntocinon, they still waited for 12 to 18 hours before they said, it is failed. So I think if we induce, right, we have to follow this to do unnecessary. This is the message I'm giving to, not talking about this, but all the postgraduates who are listening. That if you're inducing, please give them time. It is the time which matters.
Yes.
So in fact, actually, their induction protocols are not stated so clearly. Even in that supplementary part, they are not stated. And they have also said that all their multiple centers have taken their own individual induction protocols. So therefore, I think we're not really at all very sure which induction protocol was most successful and which one we can kind of opt for in our settings. And
Reva,
they have not stillbirth rates. I would think that they talk about the Asian population, but when you go into nitty-gritty, then even in England, the medical facilities for the Asian population are not because they don't give them, but their utilization is suboptimal. So we don't really know how many of these stillbirths have actually been analyzed. They've been put into the category of stillbirths in a low-risk population. They just talk about stillbirths. So we don't know whether there was other things that were missed at the cause of those stillbirths. So I do think that I would take that with some pinch of salt unless we have some better data from our own centers.
Dr. Reva, they have not mentioned that, each center followed their own protocol, but these were the standing instruction to each center. This is what they have mentioned in that. And this is what I liked about it.
Thank you, Dr. Manju and Dr. Reva. Thank you so much. So I think till the time more studies come, the take-home message will be wait till 40 weeks and 6 days for all low-risk nullips. And of course, if we have to individualize and maybe do tests of fetal well-being between 39 weeks and 40 weeks, 6 days as we wait. Okay, thank you. Thanks a lot, all the speakers and Dr. Manju and Dr. Reva. So now we move on to the panel discussion. I'm just sharing my screen then. Can you see my screen?
Yes, ma'am, it's visible.
Please allow Madhu to unmute herself. There's a message there.
Can you see my screen? Anishta?
Not yet, not yet.
Okay, just a minute, ma'am. I'll do it again. Is it visible now?
Yes.
Okay. So we start the panel on induction of labor addressing point of care challenges. Now the challenges in labor induction are actually multifaceted. Challenges to the patient, the mother, challenges to the caregiver, and I think challenges to the hospital administration. So all kind of challenges we have here. So we'll focus on some of the challenges that we come across on a day-to-day basis.
Dr. Rinku, please make it full screen.
Okay, just a minute, ma'am.
Next one.
Is it visible now?
Not yet.
Not.
Make it full screen here.
Yes, ma'am, this one.
Yes, great.
Is it okay?
Yeah.
Okay.
Yes,
Okay.
perfect.
So we start with the panelists. Let me introduce the panelists first. They are all my friends, and I think I have come across each of them, you know, in a very special way, sometime in my professional journey. So Dr. Madhu Goyal, Associate Director, Fortis LAFM. Welcome, Dr. Madhu. Dr. Ratna Bishwas, Director, Professor, Lady Hardinge Medical College. It's great to have you, Dr. Ratna. Dr. Jayashree, my colleague in Madhukar Rainbow Hospital. Welcome, Dr. Jayashree. Dr. Swati. Dr. Swati is my colleague, and I've been working with her for the past 20 years. Dr. Aruna, welcome. She is professor and head in Hamdard Institute, Jamia. Dr. Rashmi, again, a very close friend. I've been closely associated with her. She's associate professor in UCMS and GTB Hospital. Welcome, everybody. I'll start with the first case then. So I will be basically talking about some very basic issues. Some of you may find it too basic for words, but I think these are some of the challenges that we come across. And like all the experts and speakers previously said, that sometimes, you know, successful induction does not really depend on what you do during the induction process, but how you select the patients, what you do before the induction starts. So this is a 35-year-old low-risk primary gravida, 38 weeks, nothing special about her, everything fine. And she gives you a history which is kind of suggestive of leaking for an hour. And everything is okay on examination. And Dr. Madhu, the first question to you. So no leaking observed by the doctor on duty, and everything is fine. And you know, she kind of asks you whether she should do a PV examination or not. So what will be your response, Dr. Madhu?
Dr. Rinku, practically speaking, yes, I would like to do a pervaginal check in this patient. She's 35-year-old, she's term, and although no leaking is observed, she's giving a history of clear-cut leaking. So I would do a pervaginal check, determine, you know, the status of membranes, and also if she is in labor. See, what we are doing, or what I am doing is, if it is a term prom, we are inducing the patients. We are not waiting for the patient to go into spontaneous labor. If it is a term prom, you have a choice. You can wait for the patient to go into spontaneous labor, or you can start induction. So since I work at La Femme, and you know, the LDR time counts in terms of money, that is what we are following. So I would do a pervaginal check in this patient and then go ahead with according to the PV findings.
Okay, so any difference of opinion among the panelists? Anybody else has a difference of opinion?
If the facility of Actiprom is there, I will like to do a Actiprom. If that is positive, then we will go for an induction. Otherwise not, because Actiprom is a good test. And then there is no need of doing a vaginal examination.
Okay, so how expensive is that, Dr. Aruna?
It is, it is 1,000 rupees around.
Okay, okay. So whenever you are in doubt whether there is a leaking or not, you would like to confirm.
Yeah.
Okay. Okay.
Yes.
But what about doing a PV? Would you straight away do a PV?
No, straight away I'll not like to do a PV.
So why do you differ from Dr. Madhu? Any reason? Why
See, if the leaking is there, then you need to induce. If the leaking is not there, why to do unnecessarily intervention inside?
Okay.
Although we take all precautions while doing a per vaginal examination, but still why to do unnecessarily vaginal examination?
So if there is no leaking, I think I would do sweep and stretch and leave the patient. That is probably my reason of doing a per vaginal check. And if there is leaking, I would go ahead with induction.
Right, right. So like I said, you know, there are so many opinions coming up. Very nice to see that, because there is no one right answer many times. But anyway, let's see what happened to this patient. So initial assessment, of course, was done. And then, you know, you do a sterile speculum only if the diagnosis is uncertain. In this case, it was uncertain. So they did a sterile speculum and they did not find the examination. Now, the only thing against doing a PV is that, you know, every time you do a PV, you obviously increase the risk of infection, right? And in this particular patient, PV was done, like Dr. Madhu said, most of the time we do a PV. And although theoretically, you know, most guidelines will tell you don't do unnecessary PV. So this lady had a Bishop score of around 3, a poor Bishop score, a poor modified Bishop score. Okay. And no frank leaking was demonstrated, as you already know. So Dr. Ratna, will you please take this on? What will you do? Will you decide for induction? So there was no leaking. She's term with a poor Bishop score. And no, although the history is suggestive of leaking. So Dr. Ratna, please tell me.
Yeah. If there is no definite leaking, first we have to be sure that there is no leaking. So make her cough and also cough and see whether there is anything coming out. Other thing is, even if there is no leaking on that, we can still give a sterile pad and ask her to walk around and be sure that there is no leaking before we send her off. Like if we are not thinking there's no leaking, then there is no point admitting her, doing any intervention.
Right. So another thing that we could do is do an ultrasound. You know,
yeah, that is what I was going to say.
Yes, yes. To check for AFI, you know, if the patient is sometimes very clearly kind of giving you a history, you just look for the lycopockets. So that was what was exactly done in her case. And since the AFI was okay, mother was sent back after appropriate counseling. Now she came back after 8 hours with ongoing leaking off and on. So the doctor on duty reports to you, you know, some mild off and on erratic contractions and a normal NST, very, very mild contractions. And there is clear leaking on pad and there is no other clinically significant finding. So Dr. Jayashree, do you think the doctor on duty should repeat a PV now? And I mean, it's been 8 hours, she's been leaking off and on. She's still in latent labor, from what we can understand, very erratic contractions. Will you induce her? First of all, will you like to do a PV straight away? Will you want to induce her now? And you know, further on, how will you document your pre-induction counseling if you decide for induction right now?
See, as far as I can make out, Rinku, this patient is low risk. She doesn't have any risk factors. We all know that our guidelines have changed. So I should think 10 times before I have induced this patient, right? Because obviously she is in very early labor, sometimes early labor, or what I would suggest as a latent phase of labor, right? So if somebody has done an examination on her in the morning and done a sweep and stretch on her, she is going to come back with tingling contractions, which might be a pre-labor contraction. Right. For her, I would think she's just 38 weeks, low risk. And with personal experience, I would say whenever I have induced labor, I've had more challenges than solutions, because both of us get restless during the procedure.
Right.
I would document in her care that NST is reactive, she is good, the pain can be managed simply, and if she's staying close to the hospital, I would like her to come back to my hospital when she's 3-4 centimeter or contracting every 3 minutes, 4 minutes. Because once I go into the path of induction for her, I have no justification for the induction, right? Other than the fact that she is in pre-labor. So I would rather that
she's sorry, Dr. Jayashree. She came back after 8 hours with ongoing leaking off and on. This is something probably I didn't stress on. She's having ongoing leaking off and on.
So if there is a definite incidence, like the previous Dr. Aruna had said, that if we do a prom, if we are not able to demonstrate leaking, and if I have done an actin prom test, which we all do nowadays, so if that demonstrates obvious leaking, that means she has already been leaking, then I would be happier to induce her than to leave her alone. So yeah, if I can demonstrate definitive leaking, many a times it might be just a mucoid discharge they are complaining of, but since her AFI is 9, and if the previous AFI was higher, then in all probability she is having a high leak, then I would probably induce her after taking the consent for the same.
Very good. So this is probably a high leak like you just mentioned. So you will decide for induction now. So what will be, what are the things you will kind of stress on your pre-induction counseling and plan of care? She has a poor bishop. She's been leaking for 8 hours now, 8 or 9 hours. And now she's getting admitted for induction. So what are the things that you would?
So I would have a baseline complete blood count done. I will counsel her that induction might fail, but we will give her the fullest shot. I will instruct my team not to do a PV unless there is obvious contractions, because repeated PVs is going to increase my chance of infection. I will keep my neonatologist known about it, because neonatologists are very fussy that they say if the woman is leaking for more than 18 hours, they want to do the cultures on the baby. So I need to know that every culture is wrong. So I will err on my judgment that I'll do a urine culture and a high vaginal swab if it has already been taken. Maybe give her a broad spectrum antibiotic, start her induction, monitor her intermittently, because the type of induction I would like to induce with something which is more of a prostaglandin than oxytocin drip. And when I'm inducing her, obviously intermittent monitoring, keep her on a light diet, strict temperature charting, and to see if there is any change, pulse charting, and monitor her for progress and see how she behaves because of the poor bishop score, and maybe give her the fullest of induction.
Yes.
And obviously counseling is very important, because she is going to trouble me with when is it going to happen, right?
Yes.
So then the counseling part also takes a very big role there.
Yes, yes. So obviously, it may be a long induction delivery interval, and you and I being in the private sector, we know, if we don't antenatally prepare them, not only them, I think the entire family, they can really trouble us for the next 24 to 48 hours. Yeah, thank you so much. So when should we induce term prom? I think Dr. Jayashree, you can take on with this. What kind of a protocol you follow? I know, I understand that, the protocols vary.
When I was in the UK, we used to send off all term prom patients also home and bring them back in 24 hours, just do an MST, do a high vaginal swab, do a speculum examination to look for obvious leaking, and leave her alone for up to 24 hours for them to come back in labor with the temperature charting given to them, right? But in our scenario, especially in, obviously there are any high risk fractures, like if they are group B step positive, then the scenario is different. If I'm talking about a low risk, I don't think there is any difference. Different guidelines say different things, but there's no difference. You can also induce immediately, because once our patients have leaked in our scenario, nobody is happy to go home after the leaking. They say, nahi doctor sahab, bachche ko infection ho jayega. So they don't want to go home. But I always try that. So now we have changed our protocol. We don't do a PV unless they start contracting after the speculum examination. And we start induction immediately with what we are using now, because we don't have Gemiprost or Primiprost. We are using, the gels don't work that well in prom. So we are using the Misoprost tablet. I also take consent for a misoprost tablet, because misoprost tablet is not medically recommended for induction of labor in term pregnancy. So you have to document that you are giving misoprostol, which is not a documented drug for induction of labor in a term pregnancy. And then follow up per labor. Since there is a yardstick from our neonatologists that if it is more than 18 weeks, they will do a blood culture, and if it's more than 24 hours of leaking and they have gone into labor, then they start antibiotics on the child. So no parent is happy if the antibiotic is started on the child. So we have had a lot of discussion on this. So nowadays we do induce, but I do give them 2-3 hours in hospital, see if they're contracting or not, and then start the induction.
Correct. Thank you. So like guidelines vary, but the bottom line is that we should induce within 24 hours. So as Dr. Jayashree said, that those of us who are in the private sector, most of us are usually giving a time period of anything between 6 to 10 hours, because the women leak and come after 3-4 hours. We usually try and give them 6 to 8 hours more, but finally we do induce them. We don't wait too long. But the bottommost guidelines will say induction within 24 hours. The SOGC, the Canadian guideline, says immediate induction, and so does the ACOG.
So, Rinku, when we talk about induction, we also need to look into what kind of setup you are working.
Yes,
right?
Sure.
What is the cost of monitoring going to be for the patient? Where are you going to keep the patient? Are you going to send the patient back home? And what does the patient think about it? In all this scenario, when we talk about guidelines, we need to remember, see, nowadays our patients are coming up with full labor delivery protocol. They want the cord to be clamped after 3 minutes. So they have their own choice, right? So we cannot have a uniform guideline. Right? There are patients who will come and say, oh, doc, I don't want to keep coming back to the labor room. Please induce. There are patients who will say, let me wait. So we have to take their choice into account, how heavy is the labor room, and sometimes, which resident is on duty. That also plays a role on your decision.
Yeah.
So it cannot be a uniform protocol for everything. Like when we were in Lady Harding, we were leaving term proms for a particular number of hours. But in private practice, if the patient is leaking, we are inducing. At least at La Femme, I'm inducing.
Actually, Dr. Madhu, whereas I fully agree with you that we have to individualize care, but at the same time, we have to have some institutional protocols or unit protocols in place. Because it is very important that for majority of our mothers, we try and do the same thing. That is very important. The standardization of care for each condition, I think, needs to be emphasized. And of course, every individual patient has to be given that extra amount of time and counseling and to understand what that particular patient wants. But overall, I think since the guideline says induction within 24 hours, I think anything between 6, 8, 10 hours, whatever suits your institution and your labor room at that point, we can go ahead with that. But planned delivery within 24 hours resulted in less chorioamnionitis, less endometritis, fewer admissions in the neonatal ICU, and better maternal satisfaction with no difference in neonatal infection rates or mode of delivery.
I think we should be having a good coordination with our neonatal unit, because their neonatal sepsis protocol clearly said that they have to start an antibiotic. And that statement which you just read, planned delivery within 24 hours, that doesn't mean planned induction within 24 hours. So earlier induction, maybe 3-4 hours waiting, if it's a better idea to have a delivery within 24 hours or rather less than 18 hours.
This is, sorry, Dr. Aruna, this is planned induction within 24 hours.
You have written planned delivery within 24 hours.
No, I meant induction. I'm sorry for that.
Okay.
When you look at the guidelines, you look at the guidelines, they clearly say either immediate induction, or you can offer expectant management up to 24 hours. But after that, you waiting will not improve, the maternal and the perinatal outcomes.
But that becomes one risk factor for starting an antibiotic in a neonatal sepsis protocol by the pediatrician.
The antibiotic part, but induction, I think the take-home message is induction within 24 hours.
Yes,
depending on
has to be done.
Yes.
And Rinku, I'll just like to stress that if we are waiting for 24 hours or 12, like in our institution, we are waiting for 12 hours at term prom. We start
so you
the
have
antibiotic.
a protocol?
Yeah, we wait for 12 hours. Like earlier, we used to wait for 24 hours, and then because most of the females they go into labor by that time.
60% women go into labor.
Yeah,
Yes.
So nowadays we do for around 12 hours, and means including the time then when they were leaking at home also. But most important is that residents should not be doing repeated PV examination.
Yes. Yes.
Whenever we are waiting, if we don't do PV, we won't be introducing the infection.
Yes.
So that is very
Yeah,
important.
at Lady Harding also we are inducing within 6 to 12 hours. Initially we did induce, we waited till 24, but the risk of infection was much more.
Right.
Like even after, if you say between 12 to 24, also the risk is increasing of endometritis and chorioamnionitis. And the recent studies, even the interim update that is in 2021 by the ACOG, where they have said indicated late preterm or early term deliveries. In that they have said if there is term from, then immediate induction is advocated. That is what they are saying.
Like I said, Dr. Ratna, the ACOG and the SOGC advises immediate induction, and the RCOG and the RAMSCOG says you can wait up to 24 hours. So obviously we have to individualize and see our current situation and make a departmental protocol accordingly, isn't it? But immediate induction is
idea is to actually weigh the risk of infection and the risk of cesarean section.
Yes,
so that is the important thing.
I fully agree. You have to make a balance between the two.
Yeah,
because this lady has a poor bishops also, isn't it? So that is the bottom line. So
I think the evidence is that early induction does not increase the cesarean rates.
Yes. In fact, they're saying with early induction, many of these studies which has come up, even the Cochrane study by Middleton, they have said that early induction was associated with lesser cesarean rate.
Yes.
These studies are there.
So it all depends, you see, again, what is the bishop score of the mother? All these things will depend on a lot of other factors. Anyway, coming to Dr. Aruna's point about and Dr. Jayashree also, antibiotic use in term prom. Now, when you look at guidelines, they all tell you that routine antibiotic use should be avoided. But then again, you look at your setup and you do these PVs, and then of course, the infection rate increases. But ideally speaking, you should not routinely use antibiotics. The antibiotic stewardship is also a very, very big concern. You know, a lot of antibiotic resistance is also happening. So whether you want to give antibiotics at 12 hours of leaking or maybe 18 hours of leaking is again has to be a departmental protocol. Like in the hospital that I was working before, we made a protocol of 12 hours to optimize the antibiotic use. But this is also a very, very important point. Like you said, the neonatologists, they start investigating the baby at 18 hours of leaking. So we have to again draw a balance between the two. But reality, the message is that, you know, we should not take antibiotics very casually. That is also the message I want to give. But if you look at guidelines, mostly they would say that, you know, either don't use routinely, or some guidelines like WHO says give antibiotics at 18 hours of leaking. So I would like to know, you know, what your protocol is. Maybe one person from the private and one person from the public, and you know, Dr. Aruna, what is your protocol?
Yeah, so previously that's what I said, you have to have a coordination with your neonatal unit. So previously we were not starting the antibiotic before 18 hours. But then they said they are having a lot of infection, and each and every baby they were starting the antibiotics. And they said you are giving a lot of infection, so you must be starting earlier antibiotic in your patient. So we have started giving antibiotics early. And recent, if you see the latest antimicrobial guidelines of India, that is of 2021. If you see, although we don't go for a GBS test.
No, we don't.
Don't go, nowhere we go, but still they write down, if you have not gone for a GBS investigation, then you must be starting an antibiotic in your patients. This is the criteria which they have written for starting an antibiotic. Either MP you start or Augmentin you start, but they say you have to start according to your antibiogram in your patients.
Okay, and somebody from the private sector, Dr. Swati, you want to make a comment on the antibiotic use in term prom?
So, Dr. Rinku, as you have already mentioned that in our previous institute, we had made a protocol after looking through all these guidelines and decided that we'll start antibiotics after 12 hours of leaking.
Okay.
Hello?
Okay, yeah, yeah.
Am I audible?
Yeah, you're very
And
much, you're very much audible.
And we had also decided upon waiting spontaneous onset of labor for the first 6 to 8 hours following leaking. We do give a lot of emphasis to the history of leaking given by our mothers, because the mothers that come to us in the private practice, they are quite reliable in terms of history. So even if a patient is giving a history which is strongly suggestive of leaking, I would rely on that. And then may wait for 6 to 8 hours. As far as the patients are concerned, that they may be fussy. Most of our patients were antenatally prepared for these events. They were a little bit told in these workshops about our protocols, so they were mentally prepared about and they had the knowledge as to how we deal with these situations. So, and if the situation demanded, we might admit them in the ward if they stayed far away from the hospital. But for most patients, inductions we would start after waiting for 6 to 8 hours of onset of leaking. This we had taken as a middle path between, I mean, in those times, when we had made these protocols, it was a few years back before the ACOG. At that point, we had taken a middle path between the NICE guideline and the RANSCOG, wherein one extreme was waiting for 24 hours and the other one said immediate induction. And we decided we take a middle path, we wait for 6 to 8 hours and see if somebody goes into spontaneous labor, it'll be very good for her. Otherwise, we'll induce. And as for the leak,
I think we
usually like to wait for 18 hours, 12 hours. And if they don't, hello.
Yeah.
So as far as the antibiotics is concerned, we wait for the first 12 hours. If they don't deliver in that first 12 hours, then we start antibiotic to the mother.
Okay, thank you so much. So let's see the advantage of waiting, if any. So this mother was admitted, and like Dr. Jayashree said, we have to admit such mothers. Most of the time, we can't send them home if they are giving a clear-cut history of leaking. And a spontaneous onset of labor was awaited, and a repeat PV was done after 8 hours. So 8 hours she was leaking at home, and 8 hours she's in the hospital. So she's 16 hours now. And on per abdominal examination, uterus is irritable. PV is showing 1 centimeter long cervix. So now her Bishop is 5. It is definitely better than what it was before. Sometimes waiting just, improves the Bishop score, and we are happier to, induce her. I will call this, supposing we induce her at this time, this is an induction, this is not an augmentation. The reason being that she's still in latent labor. She's not in established labor. I'm just trying to, because, when we were looking at our Robson groups and all, we used to get very confused why our Robson 1 is so high and our Caesarean rates are very high. Then we realized a lot of these mothers who were in latent labor were being classified in class 1 and not in class 2A. So now her Bishop is 5. So Dr. Swati, will you induce her now? And what is the primary inducing agent you will choose and why?
So yes, it is time for induction. She's been leaking for quite a few hours now, more than 8 hours. And since the Fishoff's is still unfavorable, it will be a good idea to use a prostaglandin. Prostaglandins, either we can choose between misoprostol. I understand it is not FDA approved for usage in term pregnancy, so we can take specific consent for that. And we can either use oral misoprostol, and sometimes many of us may choose to use a sublingual route for misoprostol, although it does put the woman at higher risk for having hyperstimulation. So these two options are there for misoprostol. Very rarely, if we feel that the leaking is not very profuse and the Bishop's is very unfavorable, then we may choose to use it cervical. But that has to be taken care that it is not, it is put in the cervix and not intrauterine. So the person who's instilling the cervical has to be careful. And then the patient has to be made lying down so that it doesn't get washed out with the liquor that is draining. But that may be the case for very few cases. So for induction, yes, with an unfavorable cervix, it will be prostaglandin.
Okay. So you would prefer a 25 microgram sublingual preparation, 4 hourly, 4 to 6 hourly? Okay.
Yes,
Anybody
that is
else
what
who
we
would
usually
try,
do.
who would do differently? Dr.
So-
Ratna, would you, what would you prefer?
We are also using misoprostol. We are using 25 micrograms sublingually, and we are repeating it every 4 hours for a maximum of 5 doses.
So
That is
anybody for oral
Yeah.
misoprostol? Yeah, please.
Yeah, we are using regularly vaginal misoprostol in leaking cases, 50 microgram first dose, followed by 25 microgram 4 hourly, maximum of 5 doses.
Sorry, Dr. Aruna, is that you? Dr.
Yeah,
Aruna?
yeah.
Please speak again. Sorry, I missed you.
Okay, so we are using a vaginal misoprostol in a case of leaking, and we are putting that in a posterior fornix, and 50 microgram. 50 microgram is a first dose, and then we repeat 25 microgram after 4 hours, and maximum of 5 doses we are using.
Okay.
And
So
and if the cervix become favorable, that is 3-4 centimeters or 5 centimeter contractions are good. Accordingly, we manage with the oxytocin.
Okay, so you are using a vaginal misoprost, even
Yes.
term prom, even in
Yes.
leaking, when you think it works.
Yes,
Dr.
yes,
Madhu?
very
Yeah,
nicely.
Dr. Madhu, what are you using? Term prom, unfavorable.
Using oral meso, 25 microgram as a solution every 2 hours.
Okay, and it works well for you?
It
works well for you? Okay. Right, Dr. Rashmi?
Yeah, we actually, if the leaking is very excessive, so we give oral meso 25 microgram tablet and 4 hourly.
So
But
nobody,
if the leaking
Dr.
is not
Jayashree,
much, like
anybody for
yeah.
gel? Yeah, tell me.
Yeah,
No,
like
so
Dr.
yeah,
Swati said, no, if leaking is not much, then we go for gel also.
Okay.
Like Swati said. Yeah.
Yeah,
when meso was not available, that time we were using gel in hardening. So if I still use it, sometimes if it is very poor bishops and not much of a leaking, I will still put a Cervigel.
Okay, and Dr. Jayashree, please.
So basically, oral, we in our institution we are using sublingual misoprostol. I think it is because the absorption is through the submucous tissue. Mucous tissue, it is absorption is better. So we are using submucous, and I don't know where are we using 50 microgram of misoprostol for patients, because
orally, yes.
Orally, yes.
Orally, yes.
So if it is oral, then I don't think vaginal 50 microgram. Is that what Aruna said?
Yes, I said vaginal 50 microgram. It has a good effect first dose because patient is not having irritable uterus that many contractions. So 50 microgram is a good, but next dose we never repeat 50. It is always a 25
Again, the
microgram
challenge
after
is
4 hours.
every time you are putting in a misoprostol, you are putting your hand in to put the vaginal misoprostol. So somehow I prefer that since the efficacy is the same, why not do a sublingual misoprostol then
Resident on duty will never leave the patient after 4 hours without vaginal examination. I think
that is what we need to give as a take-home message here, because many a times this is what should be the take-home message for all medical college and non-medical college people. But restlessly doing PV on patients increases their dislike for a normal delivery also. Leave alone what infection you are giving them.
Another thing is the risk of infection also. With every PV we do not leaking patient, the risk of infection does increase.
See, whatever it is in medical college, we are teaching a resident, and resident has to learn.
We should
so
not
they are
do
going to
repeated
do a PV.
vaginal checks. A single gel at the first vaginal check if you want to give it. Otherwise, it has to be oral misoprost.
Yeah. No, when we are putting a pervaginal misoprostol, then also even if we are not doing a PV, but putting the hand inside the vagina itself is a risk factor for infection.
It has to be oral meso.
So you are not doing any pervaginal examination after 4 hours when you are giving it orally.
No, unless
she's
in labor.
Ma'am,
labor is not established.
Ma'am, in any medical college, I can't believe this, that the residents are not doing the pervaginal examination. I can't believe this at all.
Oh no,
I think
Dr. Rinku, can I come in?
Oral is also easier because the sister can give it. So we are doing a vaginal check only if she is in labor.
I think Dr. Manju Puri has something to say. Ma'am, we would like to hear you.
Yes. So yeah, it is very, very clear. Let's not put it that all medical colleges, do PV examination every 4 hourly. It is to be
stopped. And at Harding, we have stopped doing those 4-hourly PV examinations. And it is no PV, no, I don't think so. We should do any vaginal, procedure, whether it is misoprost or it is Cervical, if we have other route which is available. So why unnecessary increase the risk of infection? So Aruna, I think I just want to convey that lots of things have changed. And maybe that is the reason why you have a higher rate of neonatal sepsis, and that is why more antibiotics are being used.
See,
so maybe if you review,
if we are putting up our fingers in the cervix, then it will introduce, it's going to
even
introduce
otherwise,
infection.
Even otherwise.
Otherwise, just
Even
otherwise. Yeah. So I don't think so. We should do any kind of PV examinations, and I'm sure your antibiotic rates and your infections would come down. That would make a lot of difference. Yeah. Thank you.
So and also the cafeteria of different type of prostaglandins we can give, and like we all discussed that in term from we would like to avoid vaginal examinations as far as possible. So we use the sublingual and the oral route, but there is definitely a role of using vaginal gels or intracervical gel in some cases, where there is a high leak. We could use that also in an individualized manner. So we've talked about these doses of misoprostol, and like we were, tell me.
Yeah, oral titrated solution also can be given, that misoprostol.
Yes, after diluting, you mean?
Yeah, diluting and then titrating with the contractions.
Yes.
That also can be given. That has a better response sometimes.
Ingu, can I interrupt? I'm not a part of it.
Of course, ma'am.
So, if you read WHO, they say, sublingual causes more hyperstimulation. So it's better to give only oral, 25 milligram every 2 hourly, such 6 dosage. So one should follow that.
Oral 25 microgram has the least hyperstimulation of all the prostaglandins.
Okay, so how do you think the intrapartum care of induced labor differs compared to spontaneous labor, Dr. Aruna? Please tell us,
so we need to, whenever the labor is induced, there are more chances of side effects, hyperstimulation, fetal distress, and infection. So you need to have a strict fetal as well as maternal monitoring in these cases. If we are inducing with, in this case, as you have given the misoprostol, so we should be having a continuous CTG monitoring. Strict CTG monitoring has to be there, and it has to be interpreted very carefully in a leaking case specifically. And maternal pulse rate again becomes maternal uterine contraction. She's not going into hyperstimulation. A very important point here I want to say, if we see the CTG in these cases, in the cases of induced labor, they need to have a more relaxation time, as reported in the book of Dr. Edwin only, that if it is a spontaneous labor, then the this uteroplacental ratio, that oxygenation ratio time period is around 92 seconds. But whenever it is an induced labor, it becomes 132 seconds. So we need to be very careful regarding the monitoring, that how contractions are coming and how it is affecting the fetal heart rate. That becomes very important, and one-to nursing care, of course.
So, I understand you're talking about the hyperstimulation, the risk of hyperstimulation in induced labor. So, which is very common, more common than we ever have, thought of. And that is why the importance of a intensive nursing care and an intensive labor ward care, especially in induced labors. So let us see what happened to this mother.
One more thing, can I just add? Induced pains are more painful than spontaneous labor pains. So that is also something we should look into. Yes. And you would require probably an epidural or whatever pain management protocol is there in the institute.
Yes, good pain management is needed in all these cases.
Absolutely. Absolutely. Point very well taken. So this lady was induced with 3 doses of 25 meso sublingually, 4 hours apart. Now she has regular moderate contractions, 2 to 3 in 10 minutes after two doses. Her CTG has been normal till now, and when a repeat PV was done, now she's finally in active labor. So we're very happy. 5 centimeter, 80% effaced. There is a descent of the head, and the mother is now extremely exhausted because you've told her 5 centimeters. She feels another probably 5 to 7 or 8 hours to go. She wants an epidural or C-section. But her CTG is looking something like this. So Dr. Rashmi, tell me, so her CTG is like this, and what will you do now? What do you think we should do? We should give her an epidural because she's asking for epidural, and this is your CTG.
So yeah, let me look at the CTG.
Yeah.
Yeah, exam tough question. Huh? So yeah, she's having good contractions actually. And I think with the contractions, she's having decelerations.
Yes.
So they are like type 1 decelerations are there.
Yes.
And
And,
contractions, how many contractions are there?
Yeah, you're right. You're right. On the right track. Probably she's getting more contractions than she can tolerate.
Yeah, so it looks like tachysystole.
Yeah, absolutely right. So what can you do about this? Can you do something about this? Otherwise, she will want an epidural or a cesarean section straight away. So you can give her a tocolytic, isn't it? Yeah.
We can give the tocolysis. Yeah.
Yes.
Tocolysis can be given because she already has taken the bisoprostol, which like sublingual was given. So by chance, if the tablet part of tablet is there, so that can be removed. Yes. She has not swallowed
like
the
Dr.
tablet.
Manju Khemani said, sublingual causes more hyperstimulation.
Yeah.
Yes. So what else can you do? What tocolytic?
Isoxaprine can be given.
Yes.
Subcutaneous can be given. So that can be given.
We are using GTN sprays, these buccal sprays. They work very well. You could give a 400 microgram buccal spray. So that works very well, isn't it? Okay. I suppose giving a tocolytic is the only thing that we can do and, make her stand up and a little more comfortable and all that.
I think pain management also, if the facility is there, epidural can be given. It should be given. Like Dr. Madhu said that induced labor contractions are much more painful than the normal labor contractions.
Yes.
So that part has to be, that is why we land up in so many cesareans actually.
Absolutely. No, absolutely right. But then, when the CTG is a little suspicious, we are not comfortable giving an epidural. But like you said, if facilities are available, give her Antenatal, give her, any pain relief option. So anything you want to tell about how to train your nurses and junior doctors to support mothers with long induction delivery interval? Because this is one of the reasons why C-sections increase, isn't it? Yeah.
See, the emotional aspect of labor and the tolerance of the patient, that is very important because in our labor rooms, we are not able to provide the like companions to the patients. So if possibility, their companionship should be there. And they should take care. Actually, what I have seen is that the hydration and the nutrition, those aspects are not taken care of when the prolonged labor is there in the busy labor rooms. So that thing is also very important, and the patient has to be encouraged, and she has to like you people are doing the antenatal classes. So antenatal counseling is very important for a woman to have a realistic for the primaries. It is very important they have a realistic view as to what is going to happen in the labor. So if they are well prepared, I think they tolerate well. So that is there.
So
and
now
all the
tell me complete.
No, I said whatever apprehension they are having, actually they should be attended to by the nursing staff, by the doctors, or whosoever is attending to the patients in the labor rooms. So that is very important.
So I think
We
there are
them
three
in the early.
components to it. One is the patient, the other is the relatives, and the third is the staff. If you have prolonged induction, for the patient, we have to be very positive with her. We have to tell her to just wait. In the early phase, she should be well hydrated. She should be given liquids. She should be mobile, because of a lot of times you will find that, in induction only the sister will tell her, you just lie down. They also have this attitude, ki CTG laga hua hai, so I should not get up. So all these things can be discussed antenatally and re-emphasized when you're doing an induction. And similarly for the relatives, because at least in our kind of setup, it is also the family which says, bahut der ho gayi, cesarean kar do. So you have to counsel them as well. Plus same instructions have to be given for the staff and your residents, that they need to have patience with the patient. You can give the ball, epidural when needed, minimum per vaginal checks. So it has to be a complete effort from all ends.
Right.
So right. So now this lady finally she started pushing 4 hours later, and she's given birth to a vigorous baby with good abgars. So do you feel she could have been managed differently?
Yeah, I feel.
Can I answer?
For the sublingual, I mean, oral would have been better. One, that is my this thing.
Yes, yes.
Oral misoprostol
very good.
would have been a better option for her.
Somebody else was saying something, no?
Jayashree, Dr. Rinku.
Dr. Jayashree, yes.
Yeah, see, when we see her CTG at 5 centimeter, there are only mild D cells which were type 1 D cells, right? That could be because of 10%. So to make it comfortable, if we can do it, she had to go further on 4 hours in labor. It is not an easy task for a woman. In this case, I would have been happy to give her an epidural. And many a times I have seen when they are 5 centimeter and fully effaced, the moment they relax, they have a full dilatation, and then you can give them an hour or two for pushing. Right? So I don't see any reason that a woman should be suffering in pain when you're going to give her the optimal time to deliver naturally, right? So what is the harm in giving an epidural? Even if there is a distress, we could do the same C-section at that time with a epidural, right? It is not going to be a deterrent for us to take her up for a C-section. And obviously there is a lot of impatience from attendants, as we said, but it is ultimately, it is the counseling. And I think the thing that I would have done differently is give her an epidural at least. I mean, she deserved that much because she has been so long through this, right?
Right. So also
I would have induced
the third dose of meso, I think, would have been avoided because
Third dose was not
needed.
Not needed. Once the labor is established,
So Dr.
I would have induced her sooner.
Sorry.
Given 2 doses of meso when she's in established labor, maybe switch over to syntocenon, epidural on demand, and I agree with Dr. Jayashree, you can do a cesarean in epidural.
Of course.
I don't know how many of you use epidocin. We do use it. So at 5 centimeter, probably epidural with epidocin, I would have given her.
Okay. So Dr. Rashmi, what is your definition of failed induction? Because, in all this discussion, what we are trying to do is reduce our failed induction rates, isn't it? We start induction with a poor bishop, and we aim to have we maximize the chances of a successful vaginal delivery. So what is your definition of failed induction, and how do you reduce that in your
practice? Failed induction as such, if you read the definition, it is if you have given the complete protocol that you have started for induction, and then that is not labor is not starting after full cycle, then that is the failed induction. Okay, so it is not about the induction to delivery interval. So it is about failed induction is when the labor is not getting established.
Active labor has not started. Is that what you mean? Active labor has not started.
Active labor has not started. Okay, and regarding the total time, like you are saying 36 hours, so it is like she will have a prolonged, she is a primary gravida, so she will have a prolonged latent phase. So we have to give due consideration to the prolonged labor phase. The active phase actually should not be very prolonged. So the arrest or the delay occurs in the active labor. So that is what even now the definition of active labor is also getting
prolonged.
So it is getting pushed lately. Like we look at WHO charts, the partograph, the labor record they have now started.
Is 5 hours, 6 hours.
Right.
The giving adequate time for latent phase to progress to active labor is the most important catch, I think. So giving at least 18 hours and giving adequate oxytocin before declaring it as a failed induction of labor. And there is a role of giving rest also to the patients.
If it is not an urgent indication for induction, so it is always better to give rest for 24 hours and then go to some
Dr.
other.
Mishra, please take on your second case.
Okay. So after so much detailed discussion on the methods of induction on this practically day-to-day very important topic, we move on to our next case. And so this is, she is a primary gravida attending a regular antinatal clinic. At 32 weeks of gestation, she had history of itching all over the body for last 1 month, which was more on the palms and soles. It used to get worse at night, and it was gradually increasing. So by this clinical history, we know we are heading on to a medical complication with obstetric cholestasis of intrahepatic cholestasis of pregnancy. So this patient, there was no other any other complication as far as other with regard to fetal growth, which it was normal. And when we investigated, her liver functions tests were deranged. The AST was 96, ALT was 180. And her serum bile salts, which is diagnostic for cholestasis of pregnancy, it came out to be 103. So it confirmed the diagnosis, and she was started on ursodeoxycholic acid. So yes, Dr. Rinku, please, yes, move the slide.
Yeah, I'm just moving. Just a second.
Next, please.
I don't know why it got stuck. Just a second.
No issue. So my question to Dr. Madhu. Yes. So so when is termination of? Are you there, Dr. Madhu? Or maybe Dr. Aruna ma'am can take this question. So when is termination of pregnancy warranted in this patient? So at 32 weeks.
Right. So ACOG guidelines have latest has come, and they said that whenever it is more than 100, we need to terminate the pregnancy between 34 to 36 weeks, preferably at 35, 36 weeks around. We should be terminating because of bile acid causing a cardiotoxicity in a baby. So let me continue the pregnancy for next 2 to 3 weeks. We can get a bile acids repeated, but as such it has not.
Follow up this patient.
Yeah, that's what a weekly follow-up is needed in this case. As such, repeating the bile acid can be done after 1 week or 10 days, but our decision should have been there. Once it is 100, it is too high. We can think of starting, as the studies has shown, that if your ursodeoxycholic acid is not affecting, then you can think of starting rifampicin, although I have not given to any patient yet.
We are also not using rifampicin, so we are giving ursodeoxycholic.
Yeah, but they say that it has got not much effect in this much high bile acids.
Next slide, please. Yes. So this has already been told by Dr. Aruna that when the levels of the serum bile, the bile salts are more than 100 millimoles per liter, so we have to individualize the patient, but we have to offer her delivery at 36 plus minus, nearing 37 weeks. And between 34 to 36 weeks, there are certain indications, then we can think of individualizing the patient and maybe offer her delivery. Like if she has excruciating and unremitting maternal pruritus, which is not relieved with ursodeoxycholic acid. And if there is a history of a previous stillbirth before 36 weeks, which was because of ISCP, and she is a case of recurrence in this pregnancy, or there is a pre-existing or acute hepatic disease, and there is evidence of worsening liver function. So I would like any other point other panelists would like to mention in this patient. That at 32 weeks with 103 serum bile salts, what are we going to?
So in this case, if even one level, like the last seminar, I think Dr. Manju Puri gave an excellent lecture. So we might see if we are following her up with the bile acid levels, many times the bile acid level might come down. Right? But even then, if one noted documented level of more than 100 is seen in a patient, that patient definitely needs a close surveillance and delivery anytime after 34, 35, 36 weeks. I mean, we should not go beyond 36 weeks in such patient. And also, when we are delivering, we should discuss steroid, because if it is after 34 weeks, I would like to emphasize, don't give steroid to the patient and deliver.
Yes, rightly said. Okay, so we move on to the next slide. Dr. Rinku? Yes. So, so now this patient had a follow-up with weekly testing of the serum bile acids and the liver function test. And after 4 weeks, the LFTs, they improved. But the bile salts, they came down to 14 after starting UDCA. And she was induced and delivered at 37 weeks, 2 days with a baby boy, healthy baby weighing 2.6 kg. So as rightly said by Dr. Jashi, sir. So once the level, they are more than 100, we have to terminate the pregnancy at 37. Okay, so we, I think next slide, please. Yes, please, next slide. So if we have a different case scenario, like Dr. Ratna, ma'am. So what if this patient came to us with the first time serum bile salts level of 20 micromoles per liter at 37 weeks? There's a history of itching. The bile salts, it is only 20. So now, when would you like to induce and deliver this patient?
So this patient has IHCP, but it is a milder version, less than 40. So in the milder cases, we'll have to actually balance again, see the bishop scoring. And if the bishop scoring is poor and her bile acids is 20 only, then we can extend it for another week or two till 38, maybe 38 weeks. Normally, initially here at our institute, we were inducing all women irrespective of the bile acids levels at 37, but the Caesarean rate because of ISCP was very high. Then we have seen that if we prolong by a week or so, the rates do come down and patients do respond better to the induction. So if the bile acids are low, then we might wait till 38. So the guidelines even say till 39 you can wait, but in our institute we are going till 38 weeks for a bile acid which is 20.
Any other difference of opinion?
So if it is 20, I would like to take her till 39 weeks.
Yes.
Generally, we don't induce before 39 weeks at this level of bile acids.
Yes,
But
so
then we
most
have
of us
to
agree
repeat
that
it also.
Between 10 to 40, it is 39. 40 to 99
Yeah, we
is
go for it.
37, and more than 100,
More
then
than
it has
100.
to be 34 to 36.
Yes, so not exactly 34 to 36, but not going beyond 36.
Yeah, less than 40, they say anything
That's
between 37 to 39 weeks. Yes, you can, we can go till 39 weeks. But there are rare instances where we have seen stillbirths even in 20, but they are very rare, so we cannot generalize. Yes, we can go till
We have to
39.
weigh the risk of failed induction and
yes,
the number of cesareans. So next slide, please. So this already covered that we'll go ahead with the weekly testing, and we'll deliver her. We are going to deliver her somewhere between 37 to 39 weeks. So yes, now hand over to Dr. Rinku for next case.
Hey, can I just make a little comment here, please?
Yes, ma'am, sure.
Yeah. So I think we need to remember two things. One is a bile acid level of 100, and one is a period of gestation of 37. So I think the need to deliver babies prior to 37 would definitely need, we should not be delivering anyone prior to 37. It is not justified. We say 34 to 36, but it is not justified. So because even if the bile acids are 100, the mortality rate increases only from 37 weeks onwards. So that should be very clear. So all the hundreds, anytime 100 should be delivered at 37, not at 34, 36 weeks. Nishta has given very nice 3 indications wherein you need to intervene between 34 and 36 weeks. Intractable itching, previous stillbirth because of IHCP before 36 weeks, right? And any pre-existing liver disease which is getting worse. So except these, otherwise all IHCP should go at 37, where the bile acid is more than 100. But if it is between 40 and 99, then 38 weeks. Then we are not supposed to induce them unnecessarily at 37 weeks. So maybe if they're more near 99, you can do at 38. Okay, more towards 37 plus. Otherwise, you can safely go till 38 weeks. Because there was a very nice picture which I had shown in my last presentation, that the stillbirth rate increases only after 38, 39 weeks. So I think this is what is important. And the bile acids, if they are actually IHCP, then there will not be any failure of induction. Because bile acids predisposed to IHCP predisposes to preterm labor. So all those patients who we do cesareans for failed induction do not have significant IHCP at all. Right? So those bile acids are low level, and that is why we have failed inductions.
Thank you, ma'am,
So,
for beautifully
it
summarizing it.
could be because of the because of the medications we are giving. So because of that also it comes down the bile acids, ursodeoxycholic acid which we are giving.
Yes, fine. Let's go ahead. Yeah.
So, shall we move on now?
Yeah.
So there is this case scenario, a little bit challenging. She is a lady who's had a previous cesarean and no live issue, although a non-obstetrical death. And now she's 33 weeks with PPROM. And she is very keen for VBAC because she has no live issue. She wants future pregnancies also. And she is frankly leaking at 33 weeks. So, Dr. Jayashree, what is her chance of going into spontaneous labor? And if she goes into spontaneous labor, will you counsel her for VBAC?
Okay. So, so this patient is one who is throwing a googly on us, right? One, she doesn't have one live issue. She has already had a previous cesarean section. And first of all, obviously, if I am following up this patient, I will be following her up routinely for any risk factors that she has had. If it is low risk throughout and she has just leaked at 33 weeks, then obviously she comes into the hospital, definitely because of a previous cesarean and a previous IUD, she will definitely need an IPD treatment for her. We will get a scan done for her.
It is not a IUD. She's had a non-obstetric early neonatal death.
Okay. So then I will try to know the interval period between her cesarean section and the time she has conceived, but the interconceptional period and the delivery period, if it is more than 18 months at least, then I would obviously wait on her for her to have a. So I will know the indication for a cesarean section before. I will know the interdelivery time between her two C-sections. And obviously, if all are okay, then obviously I'm not going to deliver her at 33 weeks just because she has leaked. I will keep her inpatient, monitor her for vitals, check for any infection, do her high vaginal swabs, urine culture. And obviously, even if she is previous cesarean and not cesarean, I will like to wait at least till 34 weeks. That is where all the recommendation is. And then obviously, if she goes into labor, I would give her a trial. I mean, I will not deny her a trial of labor for her.
Yes, perfect, perfect. So, of course, a lot of other factors will matter, bishops and all that, but she is a candidate who can be appropriate for VBAC, right? Of course, the labor will test what will happen finally. So, Dr. Swati is with me because her phone has got discharged. So, how long will you continue her pregnancy if she does not go into spontaneous labor, Dr. Swati?
Yes. I think Dr. Jayashree also mentioned we'll offer admission to her because with her past history and now having had leaked, offering admission is a good option, and then keeping her under monitoring, maternal monitoring, fetal monitoring in the hospital. And most of the time, many women go into spontaneous labor within the first 1 week of, within the first 24 hours, almost 25 to 50% will go into labor at term, but in preterms, 50% go into labor within the first 1 week, and as much as 75% go into labor within the first 2 weeks. However, in her case, I would think crossing 34 weeks would be a good milestone because most NICUs are happy with a 34-week baby. And majority of the time, a combination of prematurity and infection is a more deadly a combination for these babies than prematurity alone. So keeping a careful eye on the maternal parameters and fetal parameters, I would like to have an expectant management till 34 weeks. Thereafter, maybe we can consider looking at her bishops and other factors if induction can be offered.
Right. So, there is this latest RCOG guideline which is very clear in saying that expectant management should continue till 37 weeks unless contraindicated because it is associated with better outcome compared to early birth. Although, of course, it has to be an individualized care. Now, any comments from any of the panelists regarding this? Because classically, we were delivering at 34 weeks. And we find it very, very challenging to go beyond 34 weeks in PPROM, and especially in the private sector, keeping the patient in the hospital for a prolonged duration of time and the economic constraints. So anybody wants to make a comment on this latest guideline, waiting till 37 weeks? Dr. Ratna?
Yeah, yes, we can wait till 36 plus 6, but most often they do either go into labor or they start showing signs of infection. So it is important to monitor them, keep a watch on the maternal pulse, on the fetal heart rate, and then temperature charting, TLC every alternate day or twice a week, and CRP also, and urine culture.
Yes.
And HVS has to be done. And sometimes there are subclinical choriomyelitis, like which is usually diagnosed when you send the histopathology, the placenta for histopathology.
Yeah, true. So,
Later.
But considering
there are subtle signs, like there is a maternal tachycardia or fetal tachycardia. There are subtle signs, and that has to be picked up, and NST has to be done to see that the fetal heart rate is going fine. There are accelerations, beat to beat variability is there, because these subtle signs, as Dr. Manju was saying yesterday in a discussion in our meeting, that we do miss out those subtle signs of choriomyelitis, and then we have I tend to have IUD. If they are, the fetus will manifest earlier than the mother. So if there is a fetal tachycardia and there's loss of beat to beat variability, then it has to be really looked up. Like you take a long strip and
monitoring, of course, goes without saying. But of course, in a case like this, like Dr. Jayashree just said, I mean, you could wait till 37 weeks.
Yes, definitely.
She's so keen for a way back, and then she probably wants a future pregnancy. But in such selected cases, maybe with very intensive maternal and fetal monitoring, we could wait. So, coming to case 4, Dr. Nishta, please.
Yes, Dr. Rinku. So moving on to the next case, 29-year-old second gravida para 1 living one with a previous normal vaginal delivery diagnosed with gestational diabetes mellitus, which is well controlled on insulin. And she is at 37 weeks of gestation with no other obstetric complication, and the fetal growth is normal. So my question to Dr. Aruna, ma'am, what are the factors which may influence your decision of timing of delivery in this, timing of terminations in these patients of GDM?
Whenever the patient is on drugs like insulin or metformin, I would like to terminate her at 38, 39 weeks. Generally on insulin, I terminate at 38 weeks. Well controlled, you can take her 38 completed, that is 39 weeks. Another is we have to think of other complicating factor in the fetus, like if she had a polyhydramnios, if she has a macrosomia. So that should also be taken into consideration whenever we are taking these patients for the termination of pregnancy.
Okay, so whenever there's a patient of diabetes, we move on. So next slide, please. So we focus on the gestational age. We focus on whether it is controlled on diet or nutrition therapy or metformin or insulin. It also depends whether the glycemic control is, whether it is controlled or uncontrolled. And as you said, it depends on the presence of macrosomia or polyhydramnios. So next slide, please. Yes. So maybe Dr. Rashmi, ma'am. Dr. Rashmi Malik? Yes. Yeah. So at what gestation, like this patient is 38 weeks GDM on insulin, well controlled with no other complications. So what gestation she should be delivered?
She's controlled on insulin, and if it is well controlled, like Dr. Aruna said, if no polyhydramnios, no macrosomia is there, like 38 to 39 actually is the age, gestational age. We don't go till 40 weeks if it is on insulin. So somewhere around 38, 39 weeks is fair enough for these patients to.
So the guidelines on this, I think they are more or less clear. So next, please. Yes. So as far as it is well controlled on diet, we can go up till 40 weeks as per the Ministry of Health and Family Welfare guidelines. But ACOG and NICE, they say 40 plus 6 even. But on insulin, we have to go till 38, 39. We usually don't go beyond that. And if it is not well controlled, there is presence of other risk factors with vasculopathies, we may have to individualize every patient and may take a decision earlier even. Okay. So next, yes. So So this patient he had a vital stable, rest all examination, general and systemic it was within normal limit. On per-abdomen examination, uterus was relaxed, full-term size. Cephalic fourth was it was palpable, liquor appeared adequate with a regular fetal heart rate, and NST was reactive. On PV examination, cervix was firm, consistency anterior 1 centimeter, cervical length 3 centimeters, membranes present, vertex -3, pelvis was adequate for the baby, and so making a bishop of 4. Now, Dr. Madhu Goel, yes. So what special principles will we follow before deciding for induction?
So we have to, check her insulin protocol, right? The day we decide the induction, normally, if she's on long-acting insulin, the evening before, you will reduce the dose, right? She has to be orally allowed initially. And on the day of induction, the fasting glucose should be done, and insulin or metformin, whatever she is on, has to be avoided. Plus, during induction.
Okay, but she has a very poor bishop. She may,
and just give me 2 minutes. And when she is in active labor, you have to monitor the blood sugar every 2 hours, right? In the night, I would like to either put a Propes or put a Cervigel for this patient. And then following in the morning, we would go on with misoprostol, oral solution. We give 25 microgram every 2 hours.
Okay. Any other panelists would like to comment? Yes, Dr. Jayashree?
I think she will respond very well to a gel. I mean, usually such patients who are second gravidas, maybe when I admit her, because I have to monitor her sugars also, we'll offer her a sweep and stretch maybe 24 hours prior in the OPD, put on a gel, and usually with one survey prime gel, even with this Bishop score, they usually respond. See, second gravidas are sometimes very dicey. When we cocktail 2 prostaglandins with them, many a times we have more problems than solutions. So I think if the gel has been started and she dilates 3 to 4 centimeter, I would rather go for a syntocinon, oxytocin augmentation rather than giving her misoprost, or we might land up with tachycystoles and other contractions, because it is, I have seen ruptures happening in second gravidas. See, recently I've seen a patient, first in the army hospital, first baby normal delivery, second induced labor, had a rupture, then she had a fit, she had Press syndrome, she lost her uterus, she lost her baby. So we have to keep that in mind when we are inducing second gravidas also. I think we have to be very gentle, and I would just go for a gel only for her.
Okay, next please. Next. Okay, so as Dr. Madhu said, that those, but as far as cervical ripening is concerned, like this patient with a poor bishop, she may, the induction delivery interval may go beyond 24 hours also. So usually we don't alter the dose of insulin on the day of cervical ripening. And once the cervix is ripened, the next dose may be withheld on the day of induction. And we have to be very careful, because her the maternal blood sugar levels, they correlate with the fetal levels. So maternal normoglycemia is very important to avoid fetal hypoglycemia. And the most important is maintain strict asepsis and avoid multiple PV examination. And patient has to be ambulatory, and she has to take fluids orally. So we don't go for NPOs. Okay, next. So now this patient was cervical ripening. She required 3 doses of Cervigel. We had given 8 hourly, and she is in latent labor even after 24 hours of Cervigel installation. Vitals were stable. Per abdomen uterus term size, mild contractions they have started. Cephalic was 2/5 palpable. Fetal heart was regular. On PV examination, the bishop has improved to 7. Now, as the discussion was going, that we will augment with syntocinon. So now my question to Ratna ma'am, how to go about intrapartum anti-hyperglycemic control in this patient?
So we'll have to monitor her sugars, and depending on her sugar levels, we will give her insulin by infusion pump. So that would give a graded insulin, and we are sure that the amount of insulin we want is going into her system. So giving a subcutaneous would not be advisable, because in the active labor, it is like a vigorous exercise, the active labor. So the requirement of insulin drastically drops down. So if you are giving an infusion, then you can change the amount of insulin which is going, or you can stop it also. But if you're giving a subcutaneous, then suddenly if she has she goes into active labor, she can have hypoglycemia. So what we generally do is monitor her sugars, and if it is less than 100, there is no need to give any insulin. But if it is between 100 and 100 to 140, then we can make a solution of like we take 50 ml of DNS and put 50 units of insulin. So that is 1 unit per ml. So we can start with 1 unit. If the sugars is between 100 to 140, but 1 unit is in DNS, dextrose normal saline. But if it is between 140 to 180, this solution has to change to normal saline. So the insulin now 1 unit in 1 ml of normal saline at the rate of 1.5 unit per hour. And that way we increase. If it is between 180 to 220, then 2 units per hour. And if it's more than 220, then around 2.25 units per hour.
So we will titrate it accordingly.
Yes, we will titrate.
So
And then if she goes into active labor, that is very important to realize that in active labor, her insulin requirement is going to really come down. So we might monitor her sugars every hourly in active labor. Okay. And do her urine ketones as and when she passes urine, do her urine ketones also.
Okay, so we know that the target sugar has to be maintained between 72 to 126, and urine ketone testing 4 hourly, and in latent labor we do dextrose charting 2 hourly by a glucometer. So once active labor starts, we have to ensure that the patient is getting IV fluids at 100 to 150 ml per hour in order to maintain a dextrose of 100 milligram per deciliter. And as you rightly said, that we have to titrate the insulin requirement by giving it via infusion pump. So next slide, please. Yes, so this has already been told by Dr. Ratna ma'am that we have to give insulin by infusion pump, and we have to titrate according to the blood glucose level of the patient every 2 hours. So we move on to the next slide. Yes, next case, Dr. Linko.
Yeah, so this is a words googly, but you are all Sachin Tendulkar, so it's fine. Now she is at 32 weeks with 1 previous section with no live issue. And now this lady is having loss of fetal movements for 1 day. So she's 32 weeks, 1 previous cesarean with IUD now. And she has a poor bishop. Okay, so she has 1 or 2 pregnancies ahead of her, most likely 2. So the first question I'm going to ask to Dr. Jayashree, all my questions are coming to Dr. Jayashree, I don't know how. So Dr. Jayashree, when will you induce her? Will you like to induce her immediately, or you want to give her some more time? And what specific points will you include in her pre-induction counseling?
So this is a big obstetric dilemma again, because obviously we don't want to do a preterm section for her and do sections and land up with no babies for her. However, I may be the best person doing a surgery. 2 surgeries means we are going to increase the complications for her. So for her, obviously there's a mental trauma out here. We need to spend time with her and counsel, because usually in such scenarios, attendants say, please admit and deliver, please admit and deliver. That is their first response to you. Obviously, I would like to have a chart of diagnosing why I landed up with an IUD at this point in time. And then obviously, I would like her to go back home and maybe start priming her up with mifeprin. I would like to induce and deliver her normally. This baby will not be more than 1.5 to 2 kgs of weight. And irrespective of the presentation, patience is what the key word is out here, because I have to keep her obstetric history intact, right? So obviously I would like to prime her cervix because it is a very poor Bishop score. I would like to start her with mifeprin. So we have done this before. I had a term 36-weeker who I had a IUD, previous cesarean, and we delivered her vaginally. We took 3 days. So I will prime her up with mifeprin, whatever the protocol. We follow 200 milligram 2 times a day for 2 days or 1 day, 48 hours. Then admit her, and then depending on how the Bishop score is, maybe start her up with low dose of misoprostol or subiprime gel. If it is a very totally closed tubular cervix, we can consider putting in her a Foley's catheter and do a mechanical dilatation for her, because many a times just doing a mechanical dilatation does help in these cases. And the key word I would say here is patience, because once they go into labor, they are going to deliver this baby. The chances of rupture is not very high. Obviously, that has to be taken into consideration, but I would give my heart and soul to deliver her naturally. And complications, obviously, rupture is a nightmare for us. I mean, it might further diminish our history, but usually they do deliver naturally.
Right.
So the priming and slow induction is what I would be looking at.
Right. So Dr. Swati, would you want to give her some expected management for a few days, or you want to straight away, like Dr. Jayashree said, go on to
we can because that helps in preparation. And then we can use as
Dr. Swati, you are not audible.
Dr. Swati, you are not audible.
Okay, sorry. So yes, we can wait for 24 to 48 hours, and then we can start with this process of cervical ripening, because giving time helps. And for cervical ripening, we can use prostaglandins, and as Dr. Jayashree has said, mifepristone. It can be given either as 600 milligram OD for 2 days or 200 milligram TDS for 3 days. Different protocols have been mentioned, and even Foley's catheter can be used for mechanical dilatation followed by oxytocin after 12 hours. And some literature does support use of misoprostol in these women, of course, with a lot of vigilance for watching for uterine rupture. But misoprostol has been used in previous cesarean section with IUD, and low doses are used, 25 to 50 microgram. So these are the things. There are different protocols given by different bodies.
So, like we started a discussion, and we started with Mifi, and we all know that mifepristone works very well in these patients. And there are different dose schedules: 200 milligram thrice a day for 2 days. Some people use twice a day for 3 days. But the real, the interesting part is that when I looked at the RANSCOPE guidelines, what they told, what is written there is that if it is less than 34 weeks, then you give a combination of Mifi with Meso as high as 200 micro 4 hourly for 4 doses. I mean, this was a real surprise for me. And they say that if it is more than 34 weeks, then don't use Meso. Go for the balloon with oxytocin. So I really don't know what is the cutoff gestational age before which you can use Meso more freely, and the cutoff beyond which you have to be, really careful. And as Dr. Swati said, we could use Meso at low doses, 50, maybe 25, at a higher gestational age. Now, this may be 32 weeks. So we could use a combination of Mifi and Meso if the first 1 or 2 courses of Mifi does not work. Now, before I move on, I would also like, some of you to answer, whoever wants to, what is your experience of using Mifi with live births? Because I was having a discussion with Dr. Manju Puri, and she told me that in Russia, they are using mifepristone for live births also for induction. So any comments on that?
No, I have never used Mifi
Dr.
for a live birth, but for previous LSCS we have used.
Tell us your experience of.
Yeah, so basically, in Russia, they use it as a normal protocol. But I think, Dr. Rinku, you must have gone through the literature. Yes. But we were there, and that was their first protocol. They would give, 200 milligram of mifepristone on day 1. And repeat it after 24 hours. And if the patient would not go into labor, then they would, vouch that this patient will go into failed induction. And majority of their patients would go into labor without anything.
Right,
so that is,
so yes, ma'am, very right. Actually, I looked at the Cochrane, there's a Cochrane review on Mifi in live births for induction. And they say that, it is definitely more useful than placebos, and there have been scattered reports of success, and they say that it is quite safe. So probably, at some point we'll be using it because they are working so well with our IUD previous cesarean patients.
We have here Dr. Meenakshi Chauhan from Rohtak, who's written a message saying that they are using it for live babies. So I think this is one area which can be explored.
Yeah. Okay, very, very interesting. So I just showed this picture of a cervical ripening balloon just to tell you, these double balloons, which have one balloon on the uterine side of the cervix and one on the vaginal side, that works very well in some of these cases, in some of these situations.
Rinku, we have overshot time.
Yes. I think we are about to finish. I think that's it. So
I think mifepristone for a live birth, we would have to take the permission from the Director General Health Services.
No, we are still, right now, we are not in a stage where we should be using it, Ratna, because we do not have DCGI approval. But what we are discussing is, this is one of the processes which are being followed in Russia. So not even in other countries.
But Indian studies are there, Indian studies are there, but I don't know how they got the permission.
That is in research settings they are doing.
But even for IUDs, it is a very good regime. For IUD, this 200 milligram 8 hourly for 2 days.
It is excellent. Like, response is very good. Yes, response is excellent.
35 weeks, MCDA twins, IVF conceived, both twins cephalic. You will allow induction. What is, Dr. Rashmi, you can answer this for us. 35 weeks, MCDA twins, IVF conceived. When will you advise induction?
Yeah, at around 37 weeks. I like to.
So you look at guidelines, you're perfectly right. So RANSCOG says between 36 and 37 weeks, right? So most
times. Because it is a monochorionic, monochorionic have a higher stillbirth rate.
Absolutely. And of course, when we plan a delivery like this, we have to be extremely intensive in our care, dual channel fetal monitors, ultrasound machine, 2 skilled obstetricians, we all know that. And
if it is a first vertex, not much difference in the baby weight of 2 babies. Generally, they have a good chance of delivering vaginally. It is around 60 to 75% chance is there. So that counseling has to go.
Story for us,
But the IVF babies generally they come pre-fixed, pre-decided actually to go for cesarean. That is another.
The antenatal preparation part.
Preparation is very, because success is very good if they go.
Yes.
Yeah.
So to conclude, we know that these rapidly increasing induction rates are posing a huge challenge, causing increased cesarean section rates, posing a challenge for our economy. And I think every department should have standardized induction protocols. That is very, very important. However individualized your care is, you must have a departmental protocol. And pre-induction counseling has to emphasize on the expectations, because halfway through the induction, we should not just, go by what the patient says unless we have prepared her well beforehand. And of course, the team work is very, very important, because unless we have a team work, we cannot go for inductions and, be sleepless for 3 nights together. And looking at departmental audits is, I think, the cornerstone to reduce our cesarean section rates and to improve our perinatal outcome in patients with induction of labor. So with this, I'm going to invite Dr. Manjupuri ma'am. Please, ma'am, for her concluding remarks.
So thank you so much, Rinku and Nishtha, for such a wonderful panel, and all the panelists for their wonderful inputs. Thanks to Dr. Ratna, Rashmi, Aruna, Madhu, Jeshri, and Swati for your expert inputs, and it was a very interesting panel. And I think I need to conclude it by saying that induction of labor should be taken very responsibly. I'm to say it is a decision which should be taken very responsibly, because every week the fetus spends in the womb, the fetus gains a lot. So we should not try to bring out fetuses out early just because we are insecure that some mishap might happen. So we need to remember as to what numbers need to be induced to save one mishap. I think that is very, very important. The cost effectiveness and how much is the risk to the fetus. So if we
is the way we counsel our patients. If we counsel our patients that your baby might die, but we have to tell them what are the chances. Is it 1 in 2,000, 1 in 3,000? You need to explain that 1,099 babies will be okay. Only one will die. And the other one is saying that 1 in 2,000 will die. So they get more scared with 1 in 2,000 dying, rather than if you tell them 1,999 would be okay. So I think that's the way you have to put it. And then it is actually a stepping stone for increase in cesarean section rates. So I think if we want to reduce the cesarean section rates, we need to reduce inductions. And a lot of evidence is coming in our support. So we need to share that evidence with the patient and the relatives and take a call on that. Madhu had made a very nice point that everyone should be on the same page. So the sisters, the doctors, the residents, and the consultant. So everyone should be talking the same language, and that is possible only if you have protocols. So if you have a protocol, everyone knows that this is what is the sequence which is going to be followed. So I think that is what is important. And use of infusion pumps. I'm sure COVID has brought in the use of infusion pumps. We've changed our practice in our hospital, and I think every patient, every place, we should have infusion pumps now to give oxytocin, because that would reduce the failure rates. That would definitely reduce the failure rates. So that is another thing. So thank you so much, and thank you all the delegates for being here, and thanks to the virtual platform team who has actually been there. So over to you, Rinku. And of course, I really enjoyed the debate. The topic was suggested by Rinku, but wonderful debate with Dr. Sakshi and Dr. Jyoti, and with comments from Dr. Reva and Dr. Manju Khemani. So thank you everyone, and we thoroughly enjoyed the panel and the academic activity. Thank you. Over to you, Rinku.
Thank you, Dr. Manjupuri ma'am, for this opportunity, and thank you, Dr. Nishtha, Dr. Yashika, for giving me the support, and Dr. Asmita ma'am, the AOGD team, and of course the speakers, Dr. Sakshi, Dr. Jyoti Bhaskar, Dr. Manju Khemani, Dr. Reva. Thank you so much for being with us today. And all the panelists who are my very wonderful close friends. I'm not naming each one of them, but each one of them is very close to my heart. Thank you, everybody. And thank you, Shivam and team. Okay, with that, ma'am, I'll conclude the session. Thank you.
Thank you. Thank you, ma'am. Thank you.